happy to be here. And one disclaimer, I will probably be reading from my notes a little more than I would prefer to. I'm a bit under the weather, and so I've got some extra notes to support me. So here are our learning objectives. You'll be learning the fundamentals of DBT, exploring how DBT complements CI, how to enhance your self-care with DBT skills. You will discover accessible skills. I'm going to be teaching you a lot of skills that you can use for yourself and clients. And then explore how DBT skills support healing from trauma. So I'm going to start first with a skill. So in DBT, there are 4 domains or 4 modules, and one of them is distress tolerance. And we use distress tolerance skills when you need to tolerate painful events, urges, and emotions, when you can't make things better right away. And so in DBT, it's always good to practice the skills when you don't need them, so that when you do need them, they're really accessible and familiar. So as everyone's really familiar with in CI, we often start with grounding, and I thought for here today, we would start with paced breathing. So I'll invite everyone to get comfortable, however that looks for you. If you'd like to close your eyes, you can close your eyes. It's also perfectly fine to keep them open. And turning your attention to your breath, just noticing your breath as you breathe in and breathe out. And begin to breathe deeply into your belly if that's available to you. And as you inhale, begin to slow the breath down. You might even count to 5 as you're inhaling. And as you exhale, count to 7. Or maybe you're inhaling to the count of 4, exhaling to the count of 6. But the idea is that the exhale is longer than the inhale. So inhaling long and deep. And exhaling even longer and deeper. And for those of you that have attended any of the talks on polyvagal theory, you'll find that when the exhale is longer than the inhale, that's also activating, strengthening the parasympathetic nervous system. So just continuing to slow the breath down. And then as you're ready, just gently opening your eyes, returning your attention back to the room. Okay, so I'd like to begin by sharing a little bit about Marsha Linehan, the creator of DBT. So, surprise, surprise, she seemingly had a happy childhood, and she describes herself as happy-go-lucky, confident, and a popular girl. And she also has amnesia of her life up until her 20s. So we all know when that's the case, either there was nothing to remember or there was so much going on that she couldn't process it. And if anyone's interested in knowing more about her, she has a phenomenal memoir that I have listed in my resources. So at age 18, she was diagnosed with borderline personality disorder, and she was institutionalized because she was having a total breakdown and she was suicidal. And while she was institutionalized, she made a deal with God. And she basically said, if I am able to get out of hell, I am going to help others do the same. And so DBT is her best effort to keep that vow. So fast forward decades later to the 80s, she received a grant from the National Institute of Mental Health to create a behavioral therapy to treat chronic suicidality. And it didn't really work out that well because she was using cognitive behavior therapy, which is very focused on change. It didn't work for treatment-resistant depression. It didn't work for borderline personality disorder. It didn't work for chronic suicidality. So she, through a series of trial and error and research, came up with DBT, which focuses equally on acceptance as it does on change. And the way she deepened her studies, it started out more as curiosity. She went to a Zen monastery. She thought she might be there a few months. She stayed over a year and developed an appreciation for acceptance and mindfulness, which she then has woven into really the root of DBT. So it truly has been the first successful treatment for highly suicidal people who experience their lives as being in hell and so miserable that death seems to them a reasonable alternative. So again, DBT is really taking cognitive behavior therapy to the next level by integrating mindfulness and the importance of acceptance, not just changing your thoughts, changing your feelings, and changing your behaviors, but it's also accepting yourself, accepting what is. And DBT is made up of 4 skills modules. Half of them are about change, and half of them are about acceptance. So what exactly is DBT? And I'm just curious, by a show of hands, how many folks are familiar with it prior to attending? So, what's that? A little. Okay, well, a little is plenty. And what about CBT, cognitive behavioral therapy? Okay, so CBT is considered second wave behaviorism, all about change. DBT, like I said, it integrates acceptance and change. And if you're wondering, well, what's first wave? It'll take you all the way back to your Intro to Psych course with Pavlov and Skinner. That's basic behaviorism. So this is the third wave that's really looking at the importance of acceptance and mindfulness. So it's an evidence-based behavioral therapy used to treat clients with the following. And I think everyone will have a copy or access to the PowerPoint. So if you want to look at the research, behavioral tech is Marsha Linehan's organization. And yes? I'm getting there. And actually, that is the title of the next slide, the D in DBT. Great question. Yeah. So anyway, there's research, extensive research, and access to the articles showing the evidence that DBT does, in fact, it's like the industry standard. It's the go-to for treating borderline personality disorder, ADHD, PTSD related to childhood sexual abuse, major depression, bipolar, binge eating disorders, just to name a few. And so what do all these diagnoses have in common? Anyone want to take a guess? Trauma, exactly. So, trauma is at the root of them, and even though we have the DSM criteria that are all descriptions of the behaviors that these folks would display, it's not an explanation. Trauma is the explanation. And so each of these diagnoses is representing clusters of trauma-based symptoms. And so rather than pathologizing the client, we want to understand these are the various ways that trauma is manifesting. So the person with depression had to repress their feelings to survive. The person with a disordered eating, there could be a need for control. Hello? Okay. I have sound again. Okay, so, whoops, that doesn't seem like the right slide. Okay, the D and DBT is coming up next. So the importance in how we work with CI and DBT, notice on the slide, after is highlighted, it's in bold, it's underlined, it's in a different color. After the inquiry, now what? So we're not doing CBT while you're doing a demo or submitting videos for certification. We separate the two. So after the inquiry, then we start bringing skills in. We don't want to bring the skills in too soon because first there needs to be compassion and acceptance. And so this is the now what. So even with awareness of our triggers and their relationship to our childhood traumas, there will still be challenges in daily living. And learning skills can support the work that you've already done in CI. So after the inquiry, now what could actually be the subtitle for this presentation. But first things first, CI participants have given their consent to learn and practice CI. They didn't register for a DBT class. They are not consenting to you teaching them skills during their inquiry. So important to have those boundaries around that. And I even had to watch myself when I was first starting with CI because I was trained in DBT first. And so I watched that part of myself that was the teacher that wanted to bring skills in, and it was important to rely on straight DBT and knowing the importance and the power of the skills and stepping stones. So again, we don't dive right into change. First, we have to create safety and connection with the client. In fact, the official DBT standard protocol begins with mindfulness, which is all about acceptance. So everyone kind of getting the vibe here, we're not diving right into change and to teach skills. So once you've completed the inquiry, likely multiple inquiries, you've brought the client into their body, they've named their feelings, you've compassionately been with them with their pain, you've helped them separate their beliefs and interpretations from their emotions. You've gone back to the source of the original trauma, all the things we do in CI. Now they've gained some self-awareness, and they're motivated to go to the next level. They're ready to take 100% responsibility, including action, but may not know what to do or how to do it. And after all, why would they? Because the same person that wasn't there for them at that critical moment when they needed someone to talk to validate them, to be with them with their feelings, so that they would be seen and heard. That's the same person that wasn't there for them to teach them skills that most likely didn't have the skills themselves. So there's an assumption in DBT that people don't use effective behaviors when needed due to not knowing the skillful behavior. So there's a skills deficit. They also wouldn't know when or how to use the skills. So these skills for daily living are not only helpful for folks who have experienced trauma, and at this point, who hasn't, really, but it's something that even when I'm teaching DBT to my grad students who are finishing their training to become therapists, they're like, why didn't we learn this in elementary? Why aren't they teaching this in high school? So I'm really careful with my clients to let them know these are skills for everybody, not just for someone with a diagnosis of borderline personality disorder, or, no, I don't think you're suicidal. No, I don't think you have treatment-resistant depression. These are skills that help everybody. So for example, let's say that your client realizes why she has a hard time setting boundaries or asking for what she wants or needs. So that would be the module on interpersonal effectiveness skills. Or let's say you've got a client who wants help naming and controlling emotions rather than having their emotions control them. Or they want to develop a sense of self-efficacy. So there are skills in emotion regulation for that. Clients that have substance abuse or other addictive behaviors could benefit from learning how to regulate their emotions, tolerate distress, and be more skillful rather than reaching outside of them for a behavior or a substance to soothe their pain. And then the distress tolerance skills, how to tolerate the intolerable. So for me, I combine CI and DBT in my private practice. I find they pair very well together. I use CI for all the reasons we use CI, and then I go into skill building where the clients learn how to navigate their emotions, tolerate distress, and be more effective in relationships. And like I said, there's a lot of reasons when not to use DBT, like when you're recording a video for certification, when you're doing a demo or a practicum. Okay, here we go.